For me, the best time to use radium-223 is a patient that I think is early in their course of castration-resistant disease that is already beginning to show those signs of symptoms associated with their bone metastatic burden. So if we think about that, and because this takes 5 months or more to administer, this is a therapy that we're going to be looking for those symptoms relatively early on. Back to our case, this patient had kind of minimally symptomatic disease, wasn't necessarily on narcotics, wasn't necessarily debilitated or had decreased functional status by it. So you could argue maybe this was a little bit early, but that makes sense to me in many cases. All of our patients that have symptomatic bone metastatic disease, we want to at least be considering radium, particularly in patients who are refusing, because we just don't have other sort of non-hormonal systemic therapies that we can offer these patients. And it's got a proven survival benefit independent of the hormonal therapies that we also use. So to me, this is a great example of sort of an on-label use, using this drug in patients with bone disease that is driving the natural history, the progression of cancer, and ultimately very likely driving the survival or the death of this patient.
Initiating radium-223 earlier versus later, I think, does have advantages. Some studies have shown that there's a survival advantage of being on radium-223 versus not. And I think that the idea of adding it on earlier before the patient becomes symptomatic from their bony metastatic disease does have advantages, both for the symptomatic aspect of the patients as well as potentially for their overall disease progression. The timing at which to use radium-223 is an interesting question. I think that we have to really take the two data points together, which is the patient's clinical symptoms as well as the imaging findings. And the imaging findings in one case may suggest that the patient's disease is getting worse, but we really need to make sure that we're talking to the patient as well and getting a sense as to how they're feeling about things.
At Duke, I work in a multi-physician practice. There's 5 medical oncologists. I have my own practice, but we have tumor boards regularly. We try to work as a consensus group and together form our practice patterns. And over the last 3 years, we've incorporated radium-223 initially at the sort of later stages of metastatic castration-resistant disease in many patients who had already progressed on chemotherapy. More recently, in the earlier disease settings in patients who haven't had chemotherapy yet, and in many cases overlapping with some of our secondary hormonal therapies like abiraterone, prednisone, or enzalutamide in patients who have bone-dominant disease. And so for me, we use a lot of radium-223 in that context. And my experience in general with this has been really positive. We've been able to administer full 6 cycles more frequently, much more frequently, when we've used the agent in that earlier disease setting. We see less anemia, we've given less transfusions, we've had less breakthrough pain associated with this disease. For the most part, our patients have been able to complete that and still go on to subsequent therapies, including chemotherapies, following radium-223.
My personal experience with radium-223 as a radiologist is a little different than I think what some of the people in the oncology space or the radiation oncology space or even some of my nuclear medicine colleagues may see. One thing that I see is the imaging side of the impact of the drug. And it can be quite remarkable how patients do better. And an example, this case here, the patient had no new metastatic disease after the treatment, after 6 months of treatment, and compared to what they were before to where they are today, I think was an extremely helpful thing to see.